Hi everyone, I'm Bingyu, a third-year PhD student at the University of Pennsylvania, advised by Dr. Yong Chen. So today I'm going to talk about whether COVID-19 increases the racial and ethnic differences in the prevalence of PASC along COVID in children and adolescents. This is the work using an EHR-based cohort from the Cohort program. So let's start by understanding what PASC is. When people test positive for COVID-19, they are in acute infection phase, which lasts for 4 weeks. Some people may have symptoms while others do not. However, for many, this experience does not conclude after 4 weeks, where symptoms may persist or new symptoms may emerge. They move into the post-acute phase. So this extended experience is termed the post-acute sequelae of SARS-CoV-2 infection, also known as PASC. PASC is more common than you think. The CDC reported that among adults with COVID-19 who did not require a hospital stay, 2 out of 3 had at least one outpatient visit 1 to 6 months after diagnosis. Also, from one of the systematic reviews of long COVID in children and adolescents, the prevalence of PASC symptoms and conditions is around 25%. Although children and adolescents have fewer instances compared to the adults in long COVID, they can pose greater disease burdens as their parents have to provide ongoing care for them. So here, RECOVER is initialized by the National Institutes of Health to learn about the long-term effects of COVID and to predict, treat, and prevent PASC. RECOVER has PIs for adults and pediatrics separately, and our group oversees the statistical analysis for the RECOVER pediatric cohort. Here are some selected publications on PASC within RECOVER, such as burden, vaccination, and cardiac complications. Another concern is the racial and ethnic differences in the prevalence of PASC. CDC indicated that several studies reveal that, certain racial and ethnic groups and communities are more likely to go to the hospital related to COVID-19, which is due to social factors. For example, the Black or African American community is 2.1 times more likely to go to the hospital compared to the white group, while the Asian community is 0.7 times compared to the same white group. Moreover, a paper published on the Journal of General Internal Medicine found that compared to the white group, the Black and Hispanic patients have a statistically significant different odds of developing PASC symptoms and conditions. So, here comes our clinical question. Does there exist racial and ethnic differences in potential PASC symptoms and conditions among children and adolescents after SARS-CoV-2 infection? A classical solution is the standard regression model adjusted for measured confounders. Also in 2020, this legend paper suggested first fitting a large-scale propensity score model, followed by stratification, matching, or weighting, and then running the outcome regression model with the propensity score adjusted. However, in our setting, how many of these differences are attributable to COVID infection? To account for the differences that are attributable to COVID infection, the difference in differences approach offers a robust solution. Here on the x-axis, we have the number of days since infection within an individual, and the y-axis is the prevalence of potential PASC symptoms and conditions across the population. Earlier research primarily focused on the purple rectangle here, that is the differences after COVID infection. However, it's crucial not to ignore the differences that already existed before COVID infection. So here, the difference in differences approach works as follows. We divided the differences in 2 parts. The first represents the differences that already existed before infection, and the second is the differences that totally resulting from the COVID infection. So it's essential to note that we are assuming that the pre-existing differences remain consistent before and after COVID infection. And our primary interest lies in the yellow rectangle, that is the differences totally resulting from COVID infection. So in terms of our solution, we incorporated the difference in differences analysis in the outcome regression model so that we can control the pre-COVID racial and ethnic differences. So our retrospective cohort study is part of the recovery network. After applying the specified inclusion criteria, we included over 200,000 patients across 13 institutions in the US. Roughly half of them are non-Hispanic white, 26% are Hispanic, 20% are non-Hispanic Black, and 5% are Asian American or Pacific Islander. We excluded patients from other racial and ethnic groups due to limited sample size. Let's look at our findings. We included a comprehensive list of potential PASC symptoms and conditions, and we stratified the patients based on the severity during their COVID-19 acute phase. So here, when we speak of the minority groups, we refer to the AAPI, Hispanic, and the non-Hispanic Black, each compared to the non-Hispanic white group. Here, we use the risk difference as our comparative measure, and the blue boxes denote that at least of one of these comparative groups have a significantly difference of risk difference. For example, among the patients within the severe group, the Hispanic patients showed a significantly higher increase in the respiratory signs and symptoms compared to the white group, while the non-Hispanic Black group showed a statistically significant lower increase in the skin symptoms compared to the white group. In conclusion, the racial and ethnic differences related to COVID-19 vary across the racial and ethnic groups, the severity of acute COVID-19, and the particular PASC symptom and conditions. In summary, our study helped to understand the racial and ethnic differences in PASC after SARS-CoV-2 infection among children and adolescents. Our study covered a broad spectrum of the US pediatric population, which follows the Legend Principle 1 and 9 to generate evidence at a large scale and across a network of multiple databases. Our study handles measure confounders using propensity score matching and controls the pre-COVID racial and ethnic differences using difference in differences analysis. This aligns with the Legend Principle 5 to generate evidence using best practice and aim to minimize bias. As for future work, we will explore methods to adjust for systematic bias. Thank you so much for your attention, and welcome to my poster number 509. Thank you.